Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello, everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour or so. Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. And since we are live on these presentations, I do always want to remind you, you do have the opportunity to type questions into the question box at any time. We'll check for questions throughout, so don't feel you need to wait until the end to type your questions in. Please type them in at any time you think of them, so we have them ready to go. And always feel free to share your thoughts on Twitter, and be sure to tag us at Child Health Can. All right, so today we are going to learn about the impact and pathways of intergenerational trauma and resiliency on the mental health and wellness of First Nations peoples in Canada. The health of Indigenous children and youth in Canada is one of Children's Healthcare Canada's strategic priorities as part of our strategic plan launched last October. So this topic, obviously of great interest to our community, and given the numbers that we had registered today, one of our largest webinars in the last year, I would say. So definitely interest in this issue as it pertains to the health of Indigenous children and youth. And always when we look at health disparities in this population, we have to consider the history, which includes residential schools and other government policies that affected historically the health of Indigenous peoples, and continues to this day to have an impact on health and wellness. So it's my pleasure to welcome our presenter today, Dr. Robyn McQuaid, who is a scientist in the Culture and Gender Research Unit at the Royal's Institute of Mental Health Research, the Royal being a mental health hospital here in Ottawa. Robyn is also affiliated with the University of Ottawa. She's an adjunct professor in the School of Psychology and in the Department of Neuroscience at Carleton University as well. So it's my pleasure to hand the virtual podium over to Dr. Robyn McQuaid. Over to you.
Hi, thanks, Doug. Thank you for that introduction, and thank you to everyone who's listening in today. Before I begin, I just want to acknowledge that I'm presenting today from Ottawa, the Royal's Institute of Mental Health Research, which Doug mentioned. I know some other audience members might also be from Ottawa, so I just wanted to first acknowledge the traditional and unceded territory of the Algonquin and Anishinaabe peoples. I also wanted to say that while I'm presenting today, the work that I'll discuss is really a team effort. And it's really led by Dr. Amy Bombay, who couldn't be with us today to co-present. But all the research that I'll discuss has really been a result of us working closely together in a way that is led by her. And I'll discuss our team in a little bit more detail in the next couple slides. I first I'm going to get my slides moving here. I first also just wanted to explain a bit about my research program in the larger context of understanding stress and trauma in mental health. So I've always been focused on the impacts of stressful life experiences on mental health, and why I think this is incredibly important is you'll see some statistics I've posted here, and this is from Canadian data showing that about 1 in 3 Canadians who are 15 years and older experience some form of trauma. And of those individuals who've experienced trauma, they are 2.7 times more likely to have an anxiety diagnosis, 2.9 times more likely to have a depression diagnosis, 3.4 times more likely to have a drug use disorder, and 6 times more likely to have a suicide attempt. This is just general population statistics in Canada. But also, we know that trauma is more frequently experienced among particularly marginalized populations in Canada, and not only affects the person who experiences the trauma, but I'll talk about today that trauma can be passed down across generations to continue to undermine mental health and wellness outcomes. So this is the concept that I'll really focus on today. And so briefly, my research program has three main areas of focus, and I'll obviously be discussing the third there today. But as a neuroscientist by training, some of my work is biological in nature, asking about the biological basis of trauma and stress so we can better understand mental illnesses, looking at inflammatory factors and stress hormones and genetics. The second area of my research is really about understanding the relationship between stress, substance use, and mental health with a focus on cannabis and gender differences. And the reason for that is we know that mental illnesses and substance use disorders are highly comorbid. And so it's really more beneficial to try and understand the causes of this comorbidity. And the third part of my program, which I'll be focusing on today, is about the intergenerational impacts of trauma and resilience on the mental health and wellness of Indigenous peoples in Canada. And almost all of my work is done really with youth. So particularly some of my biological research questions are focused on adolescents and first-year university students. And the reason for that is because they have increasingly been presenting at mental health counseling services, especially, I'm working closely with Carleton. Counseling services are increasingly overwhelmed, and student stress has become a really big issue on campuses. And also with Indigenous youth. So today I'm going to talk a bit about a couple projects with adults and then focus more in terms of Indigenous youth data. And so I just want to briefly introduce the team that I work so closely with on this work. And so the first and kind of most important person to mention is Dr. Amy Bombay, who leads this work. She's a professor from Dalhousie University. She's originally from Rainy River First Nation in Ontario, and she has been working on this area for the last 12 years at least, together with myself for about 5 or 6 years now, working closely with her, and with Dr. Annis Mann, a professor at Carleton University, and Dr. Kim Matheson, who is the Culture and Gender Research Chair here at the Royals Institute of Mental Health Research and at Carleton University. And actually, Dr. Matheson does quite a lot of work in Northwestern Ontario aimed at promoting Indigenous youth resilience. And so we have a number of ongoing projects, and I'm going to touch on some of those today. Some are more at the national level, so large quantitative-based data, and I'm going to present on some of this work. And then we also have some smaller studies that are more community-based initiatives and work closely with Indigenous organizations. So really, for the last 5 or 6 years, I've been involved in helping understand and explain the impacts of trauma and stress on mental health and wellness of First Nations peoples with Dr. Bombay and Dr. Annisman and Dr. Matheson. And really, the hope is that our work will have an impact on the health and wellness of Indigenous peoples, specifically that we can provide evidence and advocate for continued need for healing and services within First Nations communities. And so I'm just going to provide a bit of background. I'm not sure where everyone's information level is at, so that we all have the same kind of set of foundational information. We know that health inequities among Indigenous peoples exist compared to general population, as they've been described really extensively. And this includes physical health, such as obesity and diabetes rates, as well as mental health, such as depression and suicide outcomes. We also know, and what's been emphasized in the final report of the Truth and Reconciliation Commission of Canada, is that the health and wellness of Indigenous children and youth continue to be impacted by the intergenerational consequences of these harmful colonization practices enforced by the Government of Canada. And so the reality, and what I'll really be presenting on today and focusing on, is that it's really not possible to understand current health disparities in the health and wellness of Indigenous youth unless we understand their history. And really, in order to start to eliminate these health gaps, we have to better understand the causes of the disparities and the evidence-based and culturally relevant strategies to address them.
Hi, Robyn.
So, yes.
If I could just interject for a second, there's a couple of people asking if you could speak a little bit louder. It seems you may have looked away maybe at some notes or something and not facing your microphone, and your volume sort of dipped a little. If you could just speak a little bit louder, that would be great. Thanks.
Sure. Can you hear me now? It's kind of at max volume here, and I'm right. I have my mouth right on it. So can you hear me okay?
That's better there, yeah.
Okay, I'll keep it very close. Thank you, Doug. Yeah. And so just also important to understand that Indigenous youth are one of the fastest growing populations in Canada. So about 50% of Indigenous peoples are less than 25 years of age. And so it's really important, and we've recognized this as well, that efforts are focused on increasing health and wellness among this group. So I need to just briefly provide a background on residential schools. I'm sure that most of the audience is very familiar and has a background on this harmful policy, but our research, and I'll talk about quite a bit about this today, is that our research has examined the long-term intergenerational impacts of residential schools. And so children in these schools were removed from their parents, their homes, and cultures, and were forced to live at residential schools, where the children not only lost their connections to their families and their communities, but also their cultures. They were taught to be ashamed of their culture and were punished for speaking their traditional languages. And many have experienced chronic abuse as well as neglect in these schools, and mortality rates were very high. So we know that residential school survivors are more likely to experience physical and mental health concerns compared to those who did not attend. And we've been working with the First Nations Information Governance Center's data, the First Nations Regional Health Survey, to contribute to some of this literature. And I'm going to talk about this data on the next slide, but we've also been able to show that survivors also do have lower levels of self-reported general health, higher levels of psychological distress, and chronic physical health problems. And so we work with what's called the First Nations Regional Health Survey, which is led by the First Nations Information Governance Center. They are a nonprofit organization and really at the core conduct national surveys and are really Canada's best source of information on First Nations peoples living in rural and remote communities. And so it's important to say that that First Nations Information Governance Center supports data sovereignty. They help First Nations communities govern and manage their own data. And part of this process is following and developing the OCAP principles, the ownership, control, access, and possession. So we work with this data within the context of OCAP. So we apply to work with this data. The board reviews and ensures that the plan is appropriate and that the data and the analyses could benefit Indigenous peoples. And also, we follow the OCAP principles. So you take a course, and so that it's really a core component of understanding data that's owned and operated by First Nations peoples. And so they have a number of surveys, but today, and the surveys that we mainly focus on, is the First Nations Regional Health Survey. So as of now, there are 3 waves of data, 2002 and 3, 2008-10, and 2015-16. So we're working currently with all waves of data. And we... This data represents, like I mentioned, all First Nations peoples living in communities and reserves across Canada. And there are 3 different age groups that we work with. So there's a children's data set, which is 0 to 11 years old, youth 12 to 17, and then adults. And so currently, we just received, Dr. Bombay and I, together with Carol Hopkins from Thunderbird Partnership Foundation, received a CHR Early Career Investigator grant to work with this data to really help inform culturally relevant risk and resiliency factors in relations to First Nations children and youth mental health and wellness. So we will just be continuing on with some of this work that we have been doing and expanding some of this work as well. So I'm going to show a graph on this slide, and I just want to emphasize that what I'm talking about today is not is not focused directly on people who attended residential schools, on the survivors of residential schools. It's on the children and grandchildren. So this is what I mean by intergenerational impact. So we're looking at the impact of having a parent or grandparent who went to residential schools. And what we have been able to demonstrate is that the effects of residential schools don't stop at the person who directly attended them, but they continue to impact subsequent generations. And so that's what I'm referring to as intergenerational trauma. So this graph is focused on psychological distress, and what you will notice on the left is that that group has no previous generation of residential school family history, and you can see that they have much lower rates of distress compared to those who have one previous generation or two previous generations of residential school family history. So we see that there is a component of intergenerational trauma here. What you might also notice in this graph, though, is that those individuals on the far right who have both a parent and grandparent who attended residential schools, so two previous generations, have higher distress rates compared to those with one generation, a parent or grandparent, and then greater than no previous generation. So why I would point that out and why that's important to discuss is because this is actually showing that there's a cumulative effect. So not only can trauma be passed down, but it can be compounding across generations. And this is an important concept because it helps support this definition of historical trauma. We have heard from Indigenous peoples and organizations that historical trauma framework and framing residential schools as a historical trauma can help reduce stigma and shame and self-blame. So in relation to personal struggles and health disparities that exist, we can relate those back directly to historical traumas. And I'm going to talk about this concept a bit more in the next couple of slides. So in terms of more recently, we have examined the effects of residential schools on other cumulative, to see whether there's other cumulative impacts to further support historical trauma. And so in this graph, we're looking at adults and looking at rates of suicide ideation on the left graph. As you can see in this graph, First Nations adults who have no family history of residential school, they report lower levels of ideation compared to First Nations adults who have one or two generations of residential school in their family. And when we look at the far right, we're actually seeing a cumulative effect. So this is looking at attempted suicide among adults, First Nations adults. And we see that on the far right, those with two generations, both a parent and grandparent who went to residential schools, they have more likely to report higher suicide attempts compared to those with one generation and those compared to none. So we're seeing, again, this kind of cumulative or compounding effect across generations and providing support for residential schools as a historical trauma. So a little bit more about historical trauma and its importance. It was originally conceptualized and framed by Dr. Maria Yellowhorse Braveheart, who said that this is an accumulative emotional and psychological wounding of the lifespan and across generations, resulting from group trauma. And it's also been suggested by others, such as Dr. Gahan, that conceptualizing First Nations people's health through historical trauma perspective can be helpful and potentially reduce stigma by emphasizing the health disparities that Indigenous peoples experience are not due to their biology or something that they did, but in fact due to the years of these traumas that have been passed down across generations. So we also know that learning about historical trauma can be beneficial. So, for example, one study that did a 4-day intervention to teach service providers about historical trauma experienced by their group led to increased awareness of these impacts, a more positive Indigenous identity, and a commitment to individual and community healing. And this has been consistent with other reports with other marginalized groups where similar findings are reported, such as LGBTQ2S peoples. But what the issue is with historical trauma in terms of evidence is that it's very difficult to empirically show with data. Documenting this cumulative effect, as you can imagine, this is very challenging to find data that that spans across multiple generations, which is what you need to test. And so that is why we have been able to do this through working with the First Nations Information Governance Center's data, which has been beneficial to help support this concept of historical trauma in a empirical way. So I'm going to move on a little bit more to discussing youth, and a couple things to consider when we're discussing Indigenous suicide is that we know that in the general population, rates are higher among Indigenous peoples than the general population, about 2 to 3 times higher is the overall general statistic. But at the same time, we know that this is greater, this disparity among Indigenous youth. So it's about 5 to 6 times higher than the general population. But the important thing is that this can, of course, vary significantly depending on many factors. And one of these is that, rates vary significantly across communities. And so some communities may have a serious concern surrounding Indigenous youth suicide, and other communities may not have this at all. And so I just want to acknowledge that and recognize that before we move forward, because our data we're looking at in many cases are national data. And so they provide some strong quantitative evidence. However, there are also some drawbacks with national data, and that is that we don't see the intricacies of the community level findings in some cases. So in this next slide, moving forward, working with the regional health survey data, I spoke a bit about adult suicide, and in this graph, we have looked more at, again, this is actually adults reflecting and reporting on when they first considered suicide, if they did, and if they had considered suicide specifically between the ages of 12 to 17. And in this graph, you'll see on the far left that for the total sample, a greater proportion of First Nations adults with a parent who attended residential school, which is reflected in that purple and blue bar, reported seriously considering suicide when they were between the ages of 12 to 17 compared to those who did not have a parent attend in the gray bar. But what you also notice is that in females, rates of suicide ideation are higher here than males, but the trends for both males and females are similar. The having a parent who attended residential school was associated with higher thoughts of suicide. And so this is very similar to a finding that we look at in youth. So this next slide is actually current youth, 12 to 17 years of age. And again, we're looking at suicide ideation, or those who seriously considered suicide in the past year, by residential school family history. So in this graph, what you'll see, again on the far left, you see that First Nations youth who have a parent who attended residential school, in that purple blue bar again, they are more likely to report seriously considering suicide before more than those in the gray bar, which is those who have a family member who did not attend residential schools. So we're seeing at least double the rates of ideation there in the difference. What you'll notice in the middle of this graph, when we're specifically looking at males and females, is that for females, we can see a large difference between the group that in the purple bar that has a parent who went to residential school, and the gray bar, which is no family history of residential school. So this effect is much greater among females than males in this particular finding. And on the right, we see that the effect of having a parent who went to residential school is actually highest among those who are 12 to 14 years of age. So you see that big discrepancy there between those who have a parent who went to residential school and those who do not in the gray bar. And so we think that this data is important for a few reasons. It highlights some of the findings that are specific to First Nations youth in some communities, which we know that female youth, not only are they having higher ideation, but their rates of suicide are exceeding that of male youth in some communities. But it also emphasizes the importance of early intervention. And we're seeing these effects really mostly among the 12 to 14-year-olds. So it's happening before the age of 12. And it really speaks to the importance of a need for early intervention and early prevention as well. And in general, our takeaway from some of these data are that past government policies are linked to current day health disparities for the youth. We continue to use this data to advocate that there are needs for more culturally relevant supports and healing opportunities for Indigenous peoples, not just for survivors of residential schools, but their children and grandchildren. And also, we use these data for educational purposes. So that we can show that while some people have considered these policies as something in the past, they did occur in the past, but they're continuing to impact current day health and wellness. And so we've also, in more recent data, so this is a graph that I'll show is the most recent wave of the regional health survey data. We wrote a chapter for the First Nations Information Governance Center's national report. And so I actually have links in my presentation where you can see the national report. And so I've just pulled some of the information from the chapter we wrote for that. And this graph I'll show is from that chapter. And specifically, we're looking at substance use because Indigenous youth themselves have identified substance use as a concern, with the majority of Indigenous youth in about 75% reporting that substance use is a main challenge to community wellness. And so in this graph, you'll see that we're looking at youth substance use by residential school family history, and we see that all of those bars on the left are those that are not affected by residential schools. So they have no family history of residential schools. And we can see that if we look at each graph, that they are significantly less likely to report using substances compared to those with a family history of residential school. So, for example, binge drinking is the light blue bar. Those not affected have much lower rates of binge drinking compared to those with a grandparent and a parent. As well, cannabis use is the purple bar there. And you can see that those youth who are not affected by residential schools in a family history have lower cannabis rates and cannabis use compared to those in the middle with a grandparent and a parent, and similar trends for other non-prescription drugs. And actually, I don't have the graph showing today, but we see this similar outcome across as well prescription opioid use as well. So it's increasing with increasing family history of residential schools. So again, current health and wellness is continuing to be impacted by residential schools. So some of the work that our team then has conducted is also examining pathways. So how is it that the trauma of one generation comes to impact the next generation? And so this figure, you don't really need to follow it exactly. I'll explain it. But basically what we're looking at in this figure are First Nations adults who have a parent who went to residential school. If they have a parent who went to residential school, then these adults themselves have a greater risk for experiencing adverse childhood experiences, adult trauma, and perceived discrimination, all of which then are tied to greater depressive symptoms. And so what this is really highlighting is a concept that we know very well in the stress literature, known as stress proliferation. So this is the idea that an initial challenge or stressful event gives rise to additional stressors and challenges. And basically, difficulties in one domain, like childhood maltreatment in your life, can favor the occurrence of behaviors or circumstances that foster later stressful exposure. So we know that this can be true when we think about stress in our own lives. It can spill over and impact stressors in other aspects of our life as well. And so this model is really extended to intergenerational stress proliferation, where the parents' stress influence children's exposure to stressors, indirectly, whether that's through social disadvantages or directly, potentially through parenting behaviors. So we've continued to look a bit at some of these pathways a bit more in detail, and in this figure you'll see that basically those who have a parent who attended residential school, which is that solid blue line or solid purple blue line there, they are at greater risk for depressive symptoms when they're exposed to early life adversity. So we'll walk you through this figure kind of at low levels of childhood adversity. Individuals mostly all show low levels of depressive symptoms, irrespective of their residential school family history. But when we examine higher childhood adversity, we see that individuals with at least one parent who went to residential schools, they are represented by that solid line again, they have higher depression scores. So again, this is providing some evidence for and highlighting really that there can be these synergistic effects that we're seeing. And the final pathway that we've looked at and something that we've also been examining is through mediating variables, or other words, what variables help us explain the relationship between childhood trauma and mental health and wellness. And so, at this point when we conducted the study, there was very little data on examining pathways and mediating variables, particularly among Indigenous peoples, that help explain mental health and wellness. So we conducted a small online survey where we recruited participants through advertisements in Indigenous community health centers, as well as emailing Indigenous organizations across Canada. And advertisements invited Indigenous peoples to participate in a study on well-being. And so in order to ensure the cultural relevance of these studies, we sought feedback from First Nations community members and changed questionnaires accordingly based on feedback. So in this study, we had 134 First Nations adults who participated. And at this time, we realized that coping processes had really been largely unexamined in Indigenous peoples, but it's highly examined in terms of other general population groups where, we know that coping is an important predictor in terms of examining the relationship between stress and how we deal with stress and mental health outcomes. So what we found was when we examined coping, emotion-focused coping processes did help explain that relationship between childhood trauma and depressive symptoms, but avoidant-focused coping did not. And so for individuals who are maybe less familiar with these coping terms, emotion-focused coping is kind of efforts to reduce or control emotional states or negative emotions evoked by stressors. And as a comparison, avoidant coping kind of minimizes or delays dealing with a stressor. Both are tied in general populations to poor mental health outcomes. And these compare to problem-focused coping, which is more aimed at managing and dealing with a stressor and is typically viewed as more adaptive coping strategy. However, in the study, we didn't find that problem-focused coping was related to depressive scores. And so some of this work is really just tied to better understanding the pathways so that we can potentially inform interventions that might be culturally relevant. And so far today, I've talked quite a bit about some of the long-term negative impacts of colonization policies on physical and mental health. But we know that Indigenous peoples have shown really incredible strength and resilience despite a history of colonization. And so I also want to make sure that we highlight that the strengths inherent in Indigenous cultures and communities can really act as protective factors and promote healing among those who've experienced residential schools and other historical traumas. So we know culture is viewed as the foundation to healing and is expressed and entrenched in First Nations languages. And the use of First Nations languages have been linked to a number of positive outcomes, such as enhanced academic performance in children and youth and strong cultural identity. And so I just wanted to take a second to point out a really great framework, the First Nations Mental Wellness Continuum Framework, which is an incredible document, and it's available online. I've got it from Thunderbird Partnership Foundation website, but it really discusses culture as healing. And if anyone's looking for more information on this topic, I would highly recommend going through and getting this document. And so our team has also been examining culture as a protective factor, and we have specifically looked at cultural identity, or how strongly we identify, and found that those who have a strong cultural identity or cultural pride, and you'll see this in the graph, it's called high in-group affect, so that's the cultural pride. Those with high in-group affect or high cultural pride are that pink dotted line there that you can follow. We see in the graph that at low levels of of perceived discrimination, basically everyone's depression symptoms are fairly low. But at high levels of perceived discrimination, high cultural pride can actually buffer this effect, essentially keeping depressive symptoms fairly low. And so this is very much in line with having a strong cultural identity as protective. And it just kind of reflects the qualitative quote that you see beside the graph, suggesting that those who are affected by residential schools describe how their cultural identity serves as a resiliency factor, and that it is important for the next generation to feel proud of their culture. And so essentially, we're emphasizing the point that cultural identity can be protective, and we see this both quantitatively through a graph and qualitatively through some studies that Dr. Bombay has done at a qualitative level. And this really leads to some recent data that we've been looking at, focusing on resilience of those with a family history of residential schools. So again, this is from the most recent data released by the First Nations Information Governance Center. It's in their national report, and we've pulled it from the chapter that we wrote for this report. And so just to show you, this graph is on those who report taking part in community cultural events sometimes or almost always. And in this graph, we have adults, youth, and children. And so we actually see the strongest effects among youth and children, and we see less strong effects among adults, but you can see that survivors who are in the yellow bar there also show this effect. But basically that youth and children who have a family history of residential school, so specifically if they have a parent who went to residential school, which is the gray bars, they are more likely to report taking part in their community cultural events sometimes or almost always compared to those in the blue bars, which are those without a family history of residential school. So we're seeing that effect where it's stronger. Taking part in community culture events is stronger if youth have a parent who went to residential school and if children have a parent who went to residential school. And we've also looked at this across another outcome. Again, this is from the national report from the First Nations Information Governance Center. And so in this particular graph, we looked at belonging to home community. And we looked at whether feelings were strong or very strong towards the home community in that sense of belonging. And we, again, don't see as strong effects among adults, but when we looked at youth in this particular outcome, we saw that the youth, again, a similar trend. So those youth who had a parent who went to residential school, they have a parent who went to residential, they are more likely to report strong or very strong feelings of belonging to their home community compared to those not affected in the light blue bar, so those who not have a parent who went to residential school. And so to us, this seems to suggest that individuals, and particularly youth, may be turning towards their communities or cultures for healing. This is something that we are starting now to examine in more detail. I'm going to talk about that just in terms of next steps on the next slide or two. But first, I just also wanted to highlight that some of these findings that I've pulled are from a chapter in the First Nations Information Governance Center's website. So their national report, Chapter 6, we wrote on residential schools and the impact. So if you're looking for more detailed effects and outcomes, more than I've provided today, certainly can go and see this report. And I also wanted to highlight something that I thought the audience might be particularly interested in, because I think many are maybe healthcare providers or work in healthcare. And so there's a second phase of this report that is also online, and you can feel free to access it, which is it's a second volume of the national report, and it talks about healthcare access for First Nations peoples living in communities. And so I just wanted to highlight these so you have these resources to go back to if you are interested. So I mentioned that currently we are examining pathways through which residential schools might come to affect cultural identity. And so we are currently seeking and looking at youth with a history of residential schools and to determine whether they're more linked to their culture. And we're asking research questions about whether youth returning to their culture, if they're returning to their culture, if they're reclaiming their cultural identity for healing. So specifically, are youth more likely to seek out and practice their culture if they have a family history of residential schools? So that's something that we're currently examining now in these data sets. And I just also wanted to highlight a bit about our current and future projects and next steps. So I've spoken quite a bit today about residential schools, and really, we've been starting to ask questions about whether there's a link between the intergenerational effects of residential schools and likelihood of spending time in foster care. So we know that there has been more collective trauma, certainly, than residential schools. We've focused on residential schools in part because it's asked in national surveys, so we're able to look at this data. But certainly there's been other collective traumas enforced on Indigenous peoples, like the 60s scoop, a period between the 1960s and 1990s where Indigenous children were removed from their homes and placed in foster care or adopted into largely white families in Canada and the US and abroad. And the purpose was for assimilation. And unfortunately, we know that today the process of removing Indigenous children from their home is continuing, where they represent about 52.2% of the children in care in Canada, but only 7 to 8% of the Canadian population. So they are continuing to be removed from their homes at really high rates. And in fact, it's been suggested that the child welfare system today is just a continuation of the assimilation policies of the residential schools. And so we're examining whether there is a link between these events. For example, youth who have a parent who went to residential school, are they less likely to live with their own biological parents? And what are the health impacts of the youth who do not live with biological parents and or other family members and who live in foster care? And so a lot of this, at a quantitative level, there is no data really examining this. And so we're currently working on this. And this is really related to a new project that we've started examining the 60 Scoop, where last spring we were approached by a group called the 60 Scoop Legacy of Canada. They're an Indigenous grassroots organization who comprises survivors of the 60 Scoop, and really who identified that there is a large gap in the literature, that we know long-term consequences of residential schools, but there's almost no quantitative data regarding the impacts of the 60 Scoop and child welfare system. There is a lot of qualitative data, and so the goal of this project is really to help them better examine and ask the questions that they want to know, which are, what are the experiences and the long-term outcomes of Indigenous individuals, families, and communities affected by the child welfare system, both during and after the 60 Scoop? And as well, what are the links between past government policies like the residential schools and with the current child welfare system and the 60 Scoop? And so based on what we know from qualitative accounts of the 60 Scoop, we do anticipate that we'll find similar impacts on the health and wellness as we're seeing in residential school survivors and the intergenerational impacts of those. And so, just highlighting a couple of the new areas that we're examining, that we've been asked to pursue, and I just wanted to highlight a bit about informing policy. So, just to take a moment to highlight that the data I've presented today, some of this was used by Dr. Bombay when she testified for the Canadian Human Rights Tribunal, which was led by the First Nations Child and Family Caring Society of Canada and the Assembly of First Nations. And it was ruled in 2016 that the federal government of Canada is discriminating against Indigenous children by providing inequitable child welfare services. And so in that decision, they cited Dr. Bombay a number of times, indicating this work. And we hope that the continued work that we do will be influential in policy and also really help to educate public about these long-term and intergenerational impacts. And I think I will end here, just wrapping up with a bit of the conclusions that we know from our work and many other work, that past government policies are linked with current day disparities, particularly among Indigenous youth, and that there's increased needs in communities associated with the family history of residential schools. And we also know that, there has been a cycle of trauma associated with the residential schools. but that Indigenous peoples are certainly turning towards their culture for strength and healing. And we're seeing this in some of the data that we've looked at, especially among youth, which we know can be protective and serve as a protective factor. So with that, I just wanted to say, thank you for listening in and for attending, and also acknowledge that this is really a group and team effort. So I've put kind of the other universities reflecting the collaborators that I work closely with, and just acknowledging that the Canadian Institute of Health Research has been funding this work. So thank you very much.
All right, thank you very much. Fantastic presentation. I mean, we've heard lots of presentations around this kind of issue at our annual conference over the years, et cetera. But it's really it's a different, unique perspective when you start to put, especially for our audience, to start to put the data behind it and really show the numbers and really, put some meat to the discussion, as opposed to hearing the stories, which are always powerful and impactful. But to put the numbers like this to it is really quite powerful as well. So thank you for that. So this is our chance to ask questions. So do type your questions into the question box. We do have a few here for you. So this one came in early on. It was asking about the suicide, when you were presenting the suicide stats. And the question is asking if these statistics are representative of First Nations across Canada. Right after this question came in, you did mention that that they were, at least some of them were, and that's a bit of a challenge because it doesn't identify the variations at the community level, et cetera. So I was just wondering are you able to sort of tease out what some of the variations are that you have demonstrated or have been demonstrated in the evidence?
So thanks for that question. So the first thing I just also want to say is that a lot of this data, so I did talk about a couple small studies where we collected information from, First Nations peoples throughout wherever they lived. But a lot of the data that I've reflected are First Nations Information Governance Center's data. So it's on reserve and rural communities. So these are community-based they're national statistics, but they're community-based. So that means that they're not reflecting urban Indigenous peoples. And so that's actually something that we've been looking to now also look at. And we've started a project where we can, Stats Canada, I don't know if everyone's familiar, but they have an Aboriginal People survey, which would more largely reflect people living off communities and off reserves. And actually that represents about half or over half of Indigenous peoples today. So we also are starting to look at more urban Indigenous peoples. But in terms of this stats, we don't have community level data. So we aren't specifically looking at one community. In order to do that, you would develop a partnership with a community, and you would work with them specifically in their data in a way that they would like you to work with it. So it's something we've talked about certainly, but we haven't done because part of our group, I mentioned Dr. Kim Matheson, does work with specific communities that are dealing with some issues around a suicide. And so there's that lens from working with communities, but our purpose for this was really to focus on that national level. But as I mentioned, there are disadvantages to that as well.
All right. The next question was asking about, so as you were presenting a number of slides showing the relationship between having one parent, a parent or a grandparent, having both two generations, a parent and a grandparent, and the trends and the differences in suicidal ideation, et cetera. They're wondering if that you will see similar trends in any population any child and youth population that's exposed to physical, sexual abuse, et cetera. You're going to see some of those trends. I was wondering if, and those are some of the experiences that were had in the residential school system. Were you able to tease out those kinds of abuses that might be common across a spectrum of children, and to tease out and quantify the actual impact that might be associated with the attack on the culture itself? Were you able to sort of separate that out in any way?
It's a great question, and this is kind of, again, getting into the limitations of the national data. So at this data center, they currently do not ask about their experiences in terms of what happened at the residential schools. So we don't know if they experienced the some of the abuse that took place. So we don't have that information. In terms of making comparisons to other populations, it can be incredibly difficult to do that. There are some literature on Holocaust survivors and their children, and so there are some similar intergenerational impacts, but of course it's really, these are vastly different traumas that took place in vastly different current situations as well, and so it's really difficult to make those comparisons. But we do know that there has been some comparisons made.
So this next question is, the question itself is an interesting comment. I'm not sure you can provide an answer. I'll ask it anyways, but it's certainly an interesting. It's an interesting question. When you hear it, you'll know what I mean. The person's saying, "Can you help me with finding the words to change a teacher's narrative in her science class?" And I'm not sure if this person is the person asking is a student in this class, but changing the teacher's narrative in her science class from a focus on First Nations peoples being biologically predisposed, and I think she means predisposed to maybe a lack of resilience or predisposed to these kinds of mental health issues, more to a focus on recognizing the impacts of the historical trauma.
Yeah, that's a really, and that's kind of that's our focus of our program, really. I mean, we're doing many other things, but one of the main messages that you would have seen come through over and over again is that you have to understand the history, and it's incredibly important. In terms of specific language, if that person would like to email me, I'd be happy to work with them, and to try and suggest some things. So I don't know exactly what even showing sometimes it's data, and that's what we found, that sometimes certain people need to see the numbers in order to understand that these are continuously impacting the health and wellness, and that they're not due exactly. I think I could try and go back to this slide. I'm not sure, but there was a slide I showed with some quotes from some leaders in this space that really. Dr. Gahan says that it's not due to their biology, it's the historical trauma, it's the intergenerational impacts that continuously are affecting mental health and wellness. So that quote by Dr. Gahan kind of, I think, says it really, really well. And I'm not sure if I answered the question, sorry, but feel free to email me to whoever had that question. Yes.
Yeah, no, that's a great comment. I think that says it well. It'd be, as a science teacher, it'd be interesting to know what their evidence is to demonstrate the biological predisposition. I mean, that would be the alternative.
Yeah, and that's really not what our data shows. Yeah.
Yeah, exactly. So the next question is asking, what interventions do you know of that might be available to children and youth experiencing suicide ideations and attempts in rural communities, just as a result of this data that you've collected? Are you aware of any interventions that you've sort of come across that are making a difference that you could share with people?
So I would suggest looking up the Indigenous Youth Futures Partnership for anyone that's interested in looking at more of the work that can potentially be working with youth and in terms of interventions. I know I've heard of certainly some sports programming that can be helpful. There's been some work, I believe, with opening up hockey schools and trying to promote team and working in sports together. So I believe there's been quite a few interventions. That's not really the area that I'm involved in currently. But Dr. Kim Matheson has this large grant that's called the Indigenous Youth Futures Partnership, and that's what they're doing. They're working in Northwestern Ontario and trying to promote youth resilience. So they're learning what the youth would like, and they're helping support them to do that work in terms of interventions that the youth feel would be most helpful, and to put the partnerships in place for that. Yeah.
We do have a question asking if any of this research has been similarly carried out with the Métis population, or the Inuit for that matter.
That's a really great question, and there has been there is a paper that I'm aware of for sure on the Inuit population and looking at intergenerational trauma and suicide, and it's something that we're looking to do more with the Aboriginal People Survey, which will reflect a number of the distinct Indigenous groups. So also looking at Métis and Inuit, but there certainly are, in terms of Inuit, I'm not sure in terms of Métis populations, but the Métis Scoop project that we're looking to start in the next little while, the person leading that is Métis, and so certainly that will include all Indigenous groups and Indigenous peoples. And so we're looking forward to starting some of that work. But yes, there are some papers for sure on Inuit.
All right, so the last question that we have, and if there are people out there that are sort of frantically typing away to try and squeeze a question in, we do have a couple more minutes, so we'll be happy to take your question. This is the last question that we have in the list right now. And they're asking, as a counselor in the addictions social services field, they find it difficult to reconcile service provision in fields that have been complicit in colonial practice. So, for example, social workers or psychiatrists, mental health workers that might have been involved in the child welfare system that have been part of the problem potentially. So they're asking, do you have any thoughts on how we work to reconcile and disrupt the effects of these policies and systems as practitioners?
That's a big question, but a really important one. I don't think I'm the best person to answer that, but I would suggest that you look up the Thunderbird Partnership Foundation, who is really focused on mental health and wellness, but particularly around substance use, and works with NADAP workers, and so in terms of service provision, I think that if you reach out to them, I think they would probably be the best people to help with that question.
And the last question that did just get sneaked in at the end here is asking, so you at one point you talked about the 3 waves of data that you were looking at. So over the course of this study, do you know if the incidence of trauma, depression, suicidal ideation, et cetera, is increasing or decreasing amongst this population over the course of this study?
Yeah, so that is a great question. So we actually just got into, so we've extensively worked with the 2008-10 data, and we've just got into work with the 2015-16 data. So that's kind of some of the initial findings I was showing, and then now the 2002 data. So that is actually one of our main plans, is to look and see how health disparities have or have not changed in the past 15 years. And so within the next month, we'll be able to answer that question, but certainly that's a priority for us, because that's a really important question, and importantly, we'll say a lot about have things changed or have they not.
So we'll look forward to things to come.
Thank you.
If you wouldn't mind sort of fast forwarding to your last slide where you had your contact information, I'd love it if people make sure they have access to that as we wrap up here. And as we wrap up, I'd love to leave it to hand it over to you just one last time. If you have any closing comments, key messages you'd like to leave the audience with, work coming up in addition to what you just mentioned that you might want people to be keeping their eye out for it, just anything you'd like to leave the audience with before we wrap up.
Well, yeah, thanks so much for being here and for listening in, for the great questions today. I mean, the biggest thing, and I've said this, but I think we need to, in general, the public needs to be educated in terms of these intergenerational impacts. And we hear, which is disheartening, some comments about these things happen in the past, and so they're not relevant anymore. And we just want to ensure that people have a better understanding. And so we're happy to share and do these webinars as much as possible to be able to show that these past government policies continue to undermine current health and wellness among the youth and children today. And so, we need to all understand that. And that's a really important component of reconciliation, that we at least have an understanding that is true and that exists. Yeah.
And with that, I think it's a great place to wrap up this presentation. So thanks very much. As always, it's educational when we talk about this issue. But as I said at the beginning, it really, we've heard the stories, we've heard the impactful stories, and it's great to put data to this so we can really start to change minds as well as hearts, I guess, maybe the way to say it. So thanks again for a great presentation.
Oh, thank you. Thanks for having me.
All right. So we do, as most people know, we do our webinars every Wednesday at 11 a.m. Eastern Time. And when you do get to watch live, you get to contribute your comments and questions to the discussion. But when you can't, we do record these sessions and make them available after the fact. And everyone registered here today will receive an email with a link to that recording when it's available, usually in a couple of days. Our next webinar will be on March 20th, and we'll be talking with Dr. Nora Fayed from Queen's University, who's been working with a team from Sick Kids in Toronto about developing patient-reported measures years related to the use of medical technology and feeding for children with complex medical needs. So this session will look at some tools that they're developing to improve engagement of patients in reporting objective feedback related to their use of these medical technologies and other devices to improve use and outcomes for these children with complex medical needs. So again, one of our priority patient populations for Children's Healthcare Canada, children with complex medical needs. So I'm sure we'll see another group of you back here next week. So thanks again for joining us today. Hopefully we will see some of you back here next week. All right. Bye, everyone.